The next speaker will be my co-chair, Paul Gaynon, and he will report on the American experience, development of the treatment of acute lymphoblastic leukemia in the United States. Please, Paul.
Well, thank you for the opportunity to visit Moscow in the spring instead of in December. The weather has been beautiful. Dr. Henze tried to summarize 50 years of experience in 15 minutes. I'm going to try to summarize about 70 years of experience. The work in COG began with the merger of CCG, Children's Cancer Group, and the Pediatric Oncology Group. The merger was very difficult. We could all agree that remission was good and relapse was bad, but then the dissension began. So we all agreed that we would call the first day of therapy day one, and we would use protocols based on the work of the Berlin-Frankfurt-Münster group. The treatment of ALO goes back to the mid-1940s when Subarow synthesized folic acid. And folic acid, as you know, overcomes the maturation arrest in acute megaloblastic anemia. Sidney Farber saw this and said, in ALL, we also have a maturation arrest, and maybe folic acid will be the answer to the problem of acute lymphoblastic leukemia. He treated a number of children with folic acid and discovered it didn't help them, it made them worse. So he went from that mistake to asking Dr. Subarow to synthesize antifols. And the first antifol that arrived was aminopterin, which achieved remission in a number of children with ALL for the first time. This was published in the New England Journal in 1950. Dr. Farber only published his successes. He did not include his failures as they were of no interest in his opinion. So when others first tried this, not all patients responded, and many were ready to give up before they continued and found the eventual remission. Following that, we arrived at our standard base platform therapy. Whether to use drugs singly or in combination was the first area of dissension, which I haven't figured out yet. But in the end, we agreed that when there was overt disease with a low growth fraction and high spontaneous cell death with replete purine pathways, drugs like vincristine and glucocorticoids and later asparaginase could induce remissions without profound myelosuppression. And then when disease burden was low, growth fraction was high, spontaneous cell death was high, purine salvage pathways were empty, antimetabolites played a larger role. So we came to Dr. Pinkel at St. Jude. Most patients were achieving remission, even though CSF was negative at diagnosis. The spinal fluid was the most common site of relapse, and he first tried 12 gray cranial radiation, cranial spinal radiation, which didn't work. He then went back with 24 gray, and 24 gray worked. So we came to our basic therapy pre-protocol 2 with vincristine, prednisone, asparaginase, and induction, consolidation with cranial spinal radiation, daily oral 6-MP, weekly IT methotrexate, and then maintenance therapy, daily oral 6-MP, weekly methotrexate. In CCG, we added vincristine prednisone pulses, which were helpful in our lower risk patients. Then the key intervention was protocol 2. There was a meeting in Gunther Henze's kitchen, I'm told, in Berlin, when the decision was made to repeat induction, protocol 1 with protocol 2. I never understood this until I had a chance to speak with Dr. Pinkel. I had been told, as I recall, that vincristine and steroids were limited to 4 weeks in induction because going beyond 4 weeks served no purpose. When I had a chance to discuss this with Dr. Pinkel in person, he said to me, no, that wasn't correct. That by the standards of the time, continuing vincristine and steroids beyond 4 weeks was thought to be too toxic because of the neurotoxicity of vincristine and the muscle weakness with steroids. So the heart, I believe, of protocol 2 is that interspersing the 1B phase, that's the wrong thing here. I don't got a pointer. Gives patients a chance to recover from neurotoxicity from vincristine and steroids, and then you can go back to it again. And this therapy was equally effective whether it was given immediately following Protocol 1B or after a wait of 2 months, which we came to call interim maintenance. As this therapy evolved in CCG, we reduced the number of cytoxins in 1B from 3 to 2, as did BFM, where BFM dropped the day 15 cytoxin, we dropped the day 29 cytoxin. And we also saw that when we gave the vincristine, Ara-C, and thiopurine as a 2-week block, even though the protocol would say day 1 and day 15, there was always a 2-week delay for count recovery that eroded the intensity of this therapy. Our critical study was the 105 study from Dr. Tubergen. In this 2 by 2 by 2 randomization, patients were randomized to either early intensive therapy with additional donomycin induction, cytoxin, Ara-C, and consolidation, or they were randomized to get delayed intensification, or both, and they were randomized between cranial radiation and extended IT methotrexate. We found that with conventional therapy alone, whole brain radiation with 8% CNS relapse and 71% event-free survival was superior to extended IT methotrexate. However, when we used intensified systemic therapy, we were able to have a similar result with either option. We extended this in 1882 to high-risk patients. At 3 years, my good friend Dr. Nachman gave a presentation at ASH saying that cranial spinal radiation was superior with 2% CNS relapse, 82% event-free survival, compared to 4% and 70% with IT methotrexate alone. But at 5 years, things had changed and outcomes were more similar. In fact, we saw fewer marrow relapses late in the IT methotrexate arm, raising the question that patients needed more parenteral methotrexate. So with intensive systemic therapy and long follow-up, IT methotrexate could replace cranial radiation for most patients. We did a study of triple therapy versus IT methotrexate, and as we had hoped, we saw a decrease in CNS relapse with IT triples, but we saw excess marrow relapses with IT triples, and a very similar event-free survival. And in fact, because these patients had CNS relapses and these patients had marrow relapses, we saw a superior survival with IT methotrexate. Because we can salvage CNS relapse, we're less able to salvage marrow relapse. We're looking at this question again in our current high-risk study with more aggressive systemic therapy. In COG, we ended up with extended IT methotrexate contrary to BFM. And as one of my parents asked me, if your 11 LPs in the first 6 months of therapy failed to cure the leukemia, do you think 1 LP every 12 weeks is going to make any difference? And I'm still looking for an answer. In terms of systemic therapy, we found that the regimen standard therapy was inferior with 61% 5-year EFS. Our best outcome was delayed intensification alone at 77%. So the combination of early intensive therapy and delayed intensification of Protocol 2 was no better than Protocol 2 alone for standard risk patients. And this enabled us to drop donomycin from induction for standard risk patients that made room for other interventions. So we focused on post-induction intensification. We have our augmented BFM therapy, so-called, that gave us a 20 percentage point advantage for our high-risk, slow, day 7 response patients in the 1882 study. And then we had 35 years of subsequent trials. And we showed repeatedly for standard risk patients, DI was helpful. We have longer and stronger on 1882. We looked at single versus double DI on 1891 with prednisone induction, found an advantage which disappeared when we used dexamethasone in induction. We compared longer post-induction intensification on 1961s, found no advantage, but stronger intensification filling in vincristine asparaginase during the breaks in consolidation and in delayed intensification gave us another 9 percentage point improvement in outcome. We also built on the methotrexate hints. In the 1991 study, we compared vincristine and escalating IV methotrexate with no rescue, so-called Capezi methotrexate with our oral methotrexate, went from 89% to 93% event-free survival. More recently, we compared 5-gram methotrexate with 3 doses of leucovorin, again based on the BFM work in the late 80s, I believe, with our Capezi methotrexate, and found a 5 percentage point advantage for 5-gram methotrexate. This means we had to treat 20 patients to help 1. We had to use 80 methotrexate infusions, prevented 1 relapse, or 0.4 kilograms of methotrexate, prevented 1 relapse. Curiously, in our T-cell population, we just presented at ASH last year that the Capezi arm was actually better than the methotrexate arm, which requires some further discussion for which I have no time right now. In our current study, we're comparing cytoxin etoposide with the cytoxin Ara-C thiopurine blocks in Protocol 1B, or consolidation, and in Protocol 2B. I asked Professor Rehm when I saw him last, where did cytoxin Ara-C thiopurine come from? Maybe Gunter knows the answer, but Professor Rehm told me he can't remember. In our 1922 study, we compared Prednisone and Dex. We used Prednisone at 40, which was the standard dose at the time, with Dex at 6. We kept Dex in the DI phase. So the question was additional Dex versus induction Prednisone. We got an improvement in outcome from 77% to 85%, a decreased CNS relapse, as was discussed. We looked at it again in our high-risk B-cell precursor patients. For the patients over 10, there was no difference with Dex at 10 per meter squared times 14 days versus Prednisone at 60 for 28 days, except for excessive toxicity with the higher dose of Dex. For the younger patients, we randomized both the steroid and the methotrexate question, and curiously, when patients got Capezi methotrexate, the steroid made no difference. When we used high-dose methotrexate, we had 91% for the Dex arm versus 83% for the Prednisone arm. So for younger patients now in COG, higher risk patients, they get high-dose methotrexate and dexamethasone in induction. We've attributed this difference, the age effect, to the age effect on metabolism of steroids. Older patients metabolize steroids more slowly. There's also an issue of the incidence of the ETV6 RUNX1, that in the younger high weight count patients, about 30% have the 1221 translocation, and this is about 7% in the older patients. We've seen emergence of AVN in our more recent studies, where we were able to decrease the steroid in the delayed intensification phase from 21 days to 7 days on, 7 days off, 7 days on. We have the incidence to about 10% AVN. The British are currently exploring intermittent dexamethasone in induction for older patients, 7 on, 7 off, 7 on. I'm looking forward to their results. We've also explored MRD using flow cytometry, which is much less expensive than the PCR approaches that the BFM has adapted. In our lowest risk group, we're only 88%, so about half of the relapses were still occurring in this large MRD negative group. As others have said, if you look at MRD effects in the first 3 years, you see MRD positive patients do worse than MRD negative, and then if you begin the clock over again at 3 years, looking at kids who are in remission at 3 years, again, MRD still has a significant impact. So MRD is the gift that keeps on giving. We've been following cytogenetics with more and more skill and thoroughness. And we find that I find quite fascinating, even within subgroups like the 119 translocation, there's substantial heterogeneity or diversity in the associated chromosomal abnormalities. So even these subsets aren't one single thing, they're diverse. And then looking at MRD within the TEL-AML1 population, we see that MRD is very significant within this population, and also hyperdiploids, very significant. So the combination of good cytogenetics, either ETV6 RUNX1 or double trisomy 410 plus good MRD gives us a very, very good low-risk group with very few relapses. We're also aware of the effects of BCR-ABL. As Gunter showed briefly, we mounted a trial with imatinib, Kirk Schultz's trial, where we gave increasing amounts of imatinib against a very, very strong, likely too strong and too toxic chemotherapy platform, increasing from cohort to cohort the amount of imatinib that we administered. And the final cohort, cohort 5, we're able to reach a 75% three-year event-free survival that has stood up over further follow-up and given us outcomes very similar to those we see with bone marrow transplant. And then, as Gunter Henze showed you, there are multiple other patient subsets that have tyrosine kinase or JAK-STAT mutations, which might be vulnerable to treatment. But the concern I have is oligoclonality. In Ph-positive ALL, the BCR-ABL is present in all the clones. But for these abnormalities, are these clonal or are they subclonal? And I don't know the answer. We're now looking more and more at immune-directed therapies, again, as Gunter reviewed. There's work in the adults with inotuzumab, showing a substantial remission induction rate with the anti-CD2 calicheamycin. In COG, we're testing blinatumomab in our current first relapse study, comparing it with our conventional MRC-based chemotherapy platform. And we're doing more and more work with the modified receptor T cells. You've seen blinatumomab before. I guess this is a bispecific immune construct that brings the CD3 positive T cells in proximity to the CD19 expressing B cells. There's about a 35% CR rate in patients with overt relapse and a better response rate in patients with lower disease burdens. We're seeing high response rates with the the chimeric antigen receptor modified T cells being used mostly as a bridge to transplant. And how this will be integrated into our current therapies isn't yet known. The cost for infusion is about $500,000 right now, but likely it'll come down. Then the question is, why do these things sometimes fail? And then again, as Gunter mentioned briefly, we're learning more about the interaction between the host T cells and the leukemia cells, learning that some leukemia cells may make PD1 ligand that binds with the PD1 receptor on the leukemia cell and blocks the T cell effect, also PDL2. I can find little data about the expression of PDL1, PDL2 on lymphoblasts, both with overt disease and with MRD. I hope to learn more. So over the years, we're now testing DI versus methotrexate alone for the lowest risk patients. This is still pending. For average risk, we're looking at the methotrexate dose in maintenance, 40 versus 20. Looking at IT triple versus IT methotrexate again. For the high-risk patients, high-risk slow response patients, Cytoxan etoposide versus Cytoxan thiopurine. Our current T-cell study is looking at at bortezomib plus the BFM-based R blocks for very high risk. And then for our first relapse study, blinatumomab, either before transplant or as a part of chemotherapy in our lower risk relapse patients. So over the years, we've seen enhanced post-induction intensification, reduction of radiation therapy, dexamethasone for lower risk patients, allocating patients by lineage, cytogenetics, presentation, and response, looking more at targeted patient subsets. Dexamethasone has particular value in T cell, as was shown by the British and by EORTC and the German group. We're looking at further work with Ph-positive ALL, We're opening our first study to use ruxolitinib in combination with our backbone chemotherapy for the patients with JAK-STAT mutations. As my friend liked to say, the most important prognostic factor is treatment. Without treatment, all the patients die. With treatment, we've been able to improve the survival at 5 years to near 90%, both for T cell and for B precursor ALL. The first big step forward was the better CNS prophylaxis, post-induction intensification, or Protocol 2, gave us another boost, and we've gone further with high-dose methotrexate and dexamethasone in later years. We've seen improvements across the board in all patient subsets except infants, which has been a very difficult population. Back in the old days, I used to be able to say that relapse ALL was the third most common disease in childhood cancer. With progress to date, it's now about the 7th most common diagnosis in childhood cancer. And as Dr. Hammond, who was for 25 years or more the head of CCG, would say, everything we've learned about childhood cancer, we've learned through research. So I'll be happy to answer any questions, and thank you for your time and your attention.
Thank you, Paul, for this comprehensive overview of the development in the United States. Are there any questions from the audience?
Is there a hand up?
I would like to ask whether you see any room for de-intensification of therapy. I mean, the trend has been intensifying therapy more or less for everybody, but there are no real attempts to reduce.
Well, for us, because we're using extended IT methotrexate through 3 years, or 2 to 3 years of therapy, I think there's a great opportunity to decrease the IT methotrexate in maintenance. I think early IT therapy is crucial to cleanse the CNS, but I think maintenance IT methotrexate only masks a CNS relapse and shifts us to a marrow relapse, which is harder to treat. So I would love to see us eliminate the maintenance IT methotrexate. We're still treating boys for 3 years. Maybe boys don't need 3 years. You know, many groups are fine with 2 years. Although when I reviewed the data from the old meta-analysis, it looked pretty worrisome. Next, as you pointed out, all ALL isn't the same. You know, the Japanese did a study of 1 year of therapy, and they reported that they only had a 60% event-free survival for the patients who were otherwise standard risk. Looking at it again, they say if a patient had ETV6 RUNX1, it was an 80% EFS at 1 year with 1 year therapy. If they were hyperdiploid, it was a 30% EFS if they were treated for only 1 year. So maybe different subsets of patients have different requirements. In our high-dose methotrexate study, we saw the biggest impact in the MRD positive patients. It was only a minor impact in the MRD negative patients. So maybe 3/4 of the patients who are high risk don't need high-dose methotrexate. So there are opportunities to diminish therapy. BFM could omit donomycin from induction, in my opinion. All right, any more questions?
Other questions?
Thank you so much.
Thank you very much.